Hello everyone, Jordan Novotny here to discuss a couple more case connections, this time from Unit 4. This time around I decided to dig deeper into Case 2 involving phenylketonuria and Case 3 which involves gout. So Case 2 reads as follows. A 4-day-old infant is being followed in your clinic. Her birth weight was 5.9 pounds and the pregnancy and birth were normal. Results from newborn screening demonstrated a phenylalanine level of 6.6 mg per deciliter. A normal range is between 1 and 2. A presumptive diagnosis of phenylketonuria was made, and additional samples were obtained for further analysis. The parents deny a family history of PKU. As a consequence of this presentation, which amino acid may become essential? PHE, or phenylalanine dietary restriction therapy, was initiated at 14 days of age with good response of plasma phenylalanine levels that dropped to within the normal range. So the question is, what are the potential causes of the presentation of phenylketonuria? So there are two main causes of the presentation of phenylketonuria. The first of which is a deficiency of the enzyme phenylalanine hydroxylase. Phenylalanine hydroxylase is responsible for the conversion of phenylalanine and an essential amino acid to tyrosine, a non-essential amino acid. If phenylalanine hydroxylase is deficient, this would create an accumulation of phenylalanine, causing damaging downstream effects in multiple ways. Tyrosine levels would drop dramatically, causing the amino acid to become essential. If tyrosine is not replenished, this impacts the production of melanin, the production of thyroid hormone synthesis, and the production of the TCA cycle intermediates acetoacetate and fumarate. These downstream effects cause a range of other disorders neurologically, dermatologically, and metabolically. The second cause of the presentation of phenylketonuria will be explained after this little last piece from Case 2. Another infant, patient B, is also being evaluated for suspected PKU. BH4 loading tests are performed on both patients, and the results are presented below. So for the BH4 loading test, tablets of synthetic cofactor are dissolved in 20 milliliters of water and dim light and administered to the patients at least 30 minutes before a meal. Blood was drawn before and 4 and 8 hours after the BH4 loading. Phenylalanine levels are determined. How would you summarize the results of this test for patient A and patient B? The results of the BH4 loading test reveal that patient B appears unable to produce the cofactor tetrahydrobiopterin, or BH4, on their own. Over time, it is observed that the patient's BH4 levels continue to drop under fasting conditions. Meanwhile, patient A's BH4 levels remain consistent and even slightly increase over the period of 8 hours. This is consistent with the diagnosis of BH4 deficiency in patient B. This cofactor is required for the hydroxylation of phenylalanine into tyrosine. So clinically speaking, presentation will likely be identical. Phenylketonuria presentations due to elevated phenylalanine levels with lowered tyrosine levels, which again cause similar downstream effects. Lastly, elevated phenylalanine levels typically build up in multiple tissues and the blood, but brain and nerve cells are incredibly sensitive to the accumulation of phenylalanine and are severely prone to tissue damage, causing lifelong consequences. So early detection is important. Okay, moving on to case number 3. A 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there is no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and his laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. The results from this individual are listed on this slide. So now for the question. What is the best explanation for the presentation of gout in this individual? And please explain why the other choices below are not consistent with the data, or what additional information you may need to decide the root cause. For the first choice, overproduction of purines, this is likely a secondary cause of von Gurk disease, and more specifically type 1 glycogen storage disease. If we remember, von Gurk disease is an inherited defect in the glucose 6-phosphatase enzyme, which shunts glucose 6-phosphate to the pentose phosphate pathway, where it will be converted to ribose 5-phosphate for purine synthesis. The purines are ultimately catabolized into uric acid, and von Gurk disease is inherited, so the patient would have to have been treated for this condition much sooner than at 47 years of age, like our patient. The patient is also not displaying an elevation in urinary uric acid, so this is likely not the culprit. For the second choice, decreased salvage of purines, this is consistent with Lesch-Nyhan syndrome, which is a defect in the hypoxanthine guanine phosphoribosyl transferase enzyme that is used for purine nucleotide salvage. If this enzyme is deficient, this will cause an increase in PRPP and purine production. This will specifically increase urate levels, but uric acid levels are also typically elevated. Lesch-Nyhan syndrome is usually detected within the first 12 months after birth, and a common presentation of these patients is self-mutilation and self-injurious behavior. Other than gouty arthritis, this patient's presentation and history do not quite fit the diagnosis, since he is coming in at 47 years of age. Finally, decreased urinary excretion of uric acid is considered a form of kidney dysfunction. Deficiency in the ABCG2 protein would cause an increase in renal urate reabsorption, which would elevate plasma urate levels without elevating urinary uric acid levels due to reduced overall renal excretion. This makes sense for the patient's history of long-term overconsumption of fructose, causing an inability for this ABCG2 protein to properly allow for urate excretion. Alright, and to put a little spin on this case, after further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that fake sugar diet soda was bad for him. He tells you he drinks between 4 and 5 liters of soda a day. What is the potential impact of this dietary modification on the presentation of gout? Now, this patient's dietary modification overwhelms the metabolism of fructose. In a normal metabolic pathway, phosphorylation of fructose into fructose 1-phosphate is a fast reaction. Then, aldolase B will slowly break down the fructose 1-phosphate into dihydroxyacetone phosphate, or DHAP, and D-glyceraldehyde. In this patient's case, he is consuming so much fructose that concentrations of intracellular phosphate are too low to meet the metabolic demands of his fructose intake. This leads to phosphate-limited ATP production. Additionally, aldolase B is unable to break down the fructose 1-phosphate fast enough because if we look back at the fructose metabolism pathway, aldolase B is the rate-limiting step. All of this will lead to chronic hyperuricemia.